Good morning, everyone. I'm Dana Corson, a media officer with the National Academies of Sciences, Engineering, and Medicine. Thank you for joining us this morning for a webinar on the report that was just released at 9 a.m. Eastern today, titled Crossing the Global Quality Chasm, Improving Healthcare Worldwide. You may now download a copy of the report and other supporting materials at www.nationalacademies.org/global health quality. And you can follow the conversation about the report on social media at #GlobalQualityChasm. For those of you not familiar with the U.S. National Academies of Sciences, Engineering, and Medicine, we are private, nonprofit institutions that provide independent, objective analysis and advice to the U.S. to solve complex problems and inform public policy decisions related to science, technology, and medicine. The National Academies operate under a congressional charter to the National Academy of Sciences that was signed by President Lincoln in 1863. For each requested study, panel members are chosen for their expertise and experience and serve pro bono to carry out the study's statement of task. The reports that result from the study represent the consensus view of the committee and must undergo external peer review before they are released, as did this report. Before I introduce today's speakers, I'd like to go over a few technical reminders. After the opening remarks and presentation, we will begin to take questions through the Q&A box located in the right-hand corner of your screen. Simply type your question in the box at any time and click Submit. We ask that you leave the box set to send your questions to all panelists. If you have any technical issues during the event, I'm going to give you the WebEx technical support phone number to dial. So that is 1-866-229-3239. And now I'd like to introduce the members of the committee who are here with us today. We have Donald Berwick, one of the co-chairs. He's President Emeritus and Senior Fellow at the Institute for Healthcare Improvement in Boston. And our other co-chair is Sania Nishtar, Founder and President of HeartFile in Islamabad and co-chair of the World Health Organization Independent High-Level Commission on Non-Communicable Diseases. We will start off today with remarks from our National Academy of Medicine President Victor Zhao, and then we will move into a presentation summarizing the report by our two co-chairs, and then we will open it up for any questions you may have. Please note this webinar is scheduled to last 1 hour. And with that, I will turn it over to Dr. Zhao.
Yes, good morning. I'm Victor Zhao, the President of the National Academy of Medicine, formerly known as the Institute of Medicine, or IOM. And I'm so pleased to welcome you to the report release of Crossing the Global Quality Chasm. You know, this is an important and timely report as the world embarks on the goal towards achieving universal health coverage by 2030. In her 2012 reconfirmation speech as the WHO Director General, Dr. Margaret Chan said, and I quote, "Universal coverage is the single most powerful concept that public health has to offer. It is our ticket to greater efficiency and better quality." So indeed, the UN Sustainable Development Goal 3 calls for UHC so that all people and communities receive the quality service they need and are protected from health threats without suffering financial hardship. In other words, achieving universal access to care must be accompanied by quality of care. Indeed, health outcomes would not improve unless the care provided is of high quality. In light of these important developments, the National Academies convened an ad hoc committee, and I quote the statement of task, to study particular prospects for improving healthcare quality globally while expanding access to preventive and therapeutic services with a focus in low-resource areas. As the committee highlights in its report, without a deliberate and comprehensive effort to improve quality of healthcare service globally, UHC will too often prove to be an empty vessel. It's so well said. I think this statement resonates with all of us so well. Actually, undertaking this study is a natural extension of our work on quality at the national academies. Nearly 20 years ago, the IOM released two landmark reports, To As Human, followed by Crossing the Quality Chasm, which called to attention the importance of quality and safety and called for fundamental changes to the healthcare system. These were followed by a series of subsequent reports over the years, which expanded on various aspects of the quality framework outlined in the two foundational reports. Now, these reports were a wake-up call for U.S. and internationally and led to great national and international reforms and impact. So today's report on global quality chasm, crossing it, is so timely and important. But I want to tell you the desire to undertake this study on global quality goes back over 10 years. When I first arrived at the IOM as its president in 2014, Hector Kelly wrote me, and I quote, "For over 10 years, IOM members Don Berwick and Sheila Leatherman have wanted to have an international developing world counterpart to domestic reports. We feel positioned to explain why quality of care is not only a local good, but a global public good." So 6 months later, in January 2015, we got enough funding to hold a workshop called Improving Quality Care in Low and Middle Income Countries, which formed the foundation of today's study. I want to thank Don Berwick, and also this is why I'm so extremely pleased today to see this report being released. Now, like To As Human, this report is also a wake-up call globally. The committee concluded, and I quote, that the global quality chasm is even greater than the quality chasm identified by the IOM United States in 2011, and that inhuman cost is much more disturbing. In short, without major attention to quality improvement, UHC will be a grievous disappointment. Delivering access to care has far too little real value for health and well-being. And I end of quote. In support of the statement, you know, the previous work of many, including Jisnu Das of World Bank, reported that low and middle income countries, the probability of a patient receiving correct diagnosis is a range of 30 to 50%. Similar studies that have attempted to estimate the probability of a patient receiving non-harmful treatment found likelihood about 45%. So you'll hear shortly that our committee also commissioned a thorough analysis to produce updated estimates for the burden of unsafe care. And as you hear in much greater detail, the committee outlined a vision for the future of healthcare globally. A major theme of this report is that quality is determined more by design of healthcare than by the frontline care delivery, and that healthcare leaders must fundamentally redesign healthcare systems using principle of systems thinking. And importantly, the significance of this report, the message is that they put squarely in the context of UHC and the current global healthcare landscape and the future digital environment. So I want to end by saying a few words about the study process. This study is a result of an extensive process. A 14-member committee was appointed in July 2017 to conduct the study, meeting 4 times over the course of the study. They also visited stakeholders in Kenya and had 1 public workshop. This report would not be possible without support and efforts of so many people. So this slide shows you our sponsors. I'd like to thank them. The USAID, NIH, President's Emergency Plan for AIDS Relief, PEPFAR, Wellcome Trust, Johnson & Johnson Global Public Health, and Institute of Global Health Innovation, Imperial College, and Medtronic. But I also want to thank the entire committee and staff for the outstanding work. They spent long hours tackling this topic, and we see their efforts reflected in this report. In particular, I'd like to thank my friends Don Berwick and Sonia Nishtar, who co-chair the committee. They've just done a fabulous job, and you'll hear from them very shortly. And I want to thank the dedicated staff to support the committee's work. Megan Sneer, Ishan Kandikar, Sarah N. Liu, Julie Pavlin, and Cheryl Ness. Finally, I'd like to point out that contemporaneously, 2 other reports on the same topic are being released, which in my mind speaks to the importance and timeliness of this topic. The WHO, World Bank, OECD released a report on July the 5th on a similar topic, and the Lancet Commission, the report will be released on September the 6th. It is our intention to collaborate with our colleagues of these reports, to learn from their work, to identify common findings and recommendations, to provide a common roadmap, and to work collectively to generate momentum for sustained implementation of care quality globally. Thank you very much for attention, and I look forward to hearing the report from our 2 co-chairs, and I want to thank them personally for their hard work. Thank you.
Thank you, Dr. Zhao. And now we will turn it over to Sonia Nishchar to begin the presentation.
Thank you very much. Good day, everybody, and thank you, Dr. Zhao, for taking the time to be with us and for your comprehensive opening address. Your support has been remarkable throughout, and on behalf of the entire committee, and especially my co-chair, Don Berwick, I would like to thank you for your collaboration and your commitment, without which this project would simply not have been possible. Let me now turn to the report itself, and before I do that, let me draw the attention of those joining us this webinar today to the hashtag Global Quality Chasm, which you can view up on the screen and which we suggest you use as you engage on social media today. Can I have the next slide, please? As Dr. Zhao just mentioned, the committee was tasked to assess how healthcare quality can be improved. And in terms of process, just to give you a snapshot, to answer this charge, the committee met 4 times face-to-face for deliberation. Our work was supported by paid consultants from the Harvard Institute on Global Health Quality, whose analysis on the burden of poor quality of healthcare we will discuss momentarily. Other consultants contributed white papers on information technology and health systems and on human factors and ergonomics. Our committee considered a number of topics which centered on the consequences of poor quality and the constraints for health systems. We took into consideration quality issues as they relate to informal workers and fragile states. We honed in on corruption, which, as you may have noticed, has remained the blind spot in health systems analyses so far. And in terms of solutions, we explored the potential of systems design thinking. We explored the potential of digital health innovations. And we fleshed out high priority research topics for further analytical work within this domain. The next one, please. There are a few top-line messages emanating from this report, which I want to quickly summarize for you. Firstly, healthcare in all settings globally today suffers from high levels of defect in quality, as Victor just mentioned as well. Our committee felt that this is damaging, this is extremely worrisome, and this wide chasm must not be taken lightly. The chasm is simply infuriating. Secondly, the committee has clearly reiterated that the current drive towards universal health coverage, which, as you all know, is the central pillar of the health-related sustainable development goal, which is SDG 3, must be paired with efforts to improve quality, or else it is likely to be, at best, as Victor describes, an empty vessel, and it could also potentially cause harm. And our report refers specifically to the policy levers which could be embedded into quality frameworks within the context of ongoing efforts to institutionalize universal health coverage within country body politics. Thirdly, our report emphasizes the importance of and the need for redesign of systems. And and its potential to make universal health coverage and the patient journey more effective, and Don is going to elaborate on that in a moment. In the fourth place, we refer to health systems of the future. In fact, the existing transformations in healthcare, and refer to the digital transformation, which present an opportunity to rapidly adopt design principles that we give a lot of priority to these in our report to improve healthcare quality. But at the same time, we also refer to the three specific challenging situations and their relevance for any effort to improve healthcare quality holistically. One of them is the setting of extreme adversity, such as fragile states, conflict situations, and refugee camps. The other one is the mammoth unaddressed issue of health care delivered by informal providers. And the third relates to corruption and collusion as they plague health systems the world over. And finally, we reiterated the need for public policy action by ministries of health, although more broadly, we call for holistic solutions that can engage all stakeholders, and the need for all of them to be mobilized in this effort. Next one, please. Briefly, we are going to organize the rest of our comments around some of the main themes in the report, starting with the current state of healthcare. Don, do you have any reflections so far, and do you want to take forward from here?
Well, thank you very much, Sonia. I want to first express my thanks, as Sonia did, to the National Academies and to Victor Zhao and his colleagues, and to our wonderful staff in getting this report done, and also express my thanks to my co-chair, Sonia Nishtara. It was a delight to work together, and we benefited from an extremely talented committee. I'm going to take the ball for a few minutes now and talk a bit about the first couple of topics, the burden of quality and our recommendations that devolve from that, and a few comments on redesign of healthcare. If I could have the next slide, please. So let's begin with a conversation about the current state. As Sonia and Victor said, our committee is not just concerned, but I would say alarmed by what we surfaced in terms of the current burden of poor quality globally, especially, but not confined only to low and middle income countries. Next slide, please. Our report has extensive analyses and appendices that bear on the calculations we did to figure out what the burden of poor quality is globally and its consequences for patients, families, communities, and for Treasury. The problems we have in available data are severe, and we're going to come to some recommendations about much better research and much better monitoring of the level of quality, but especially with the help of our colleagues at the Harvard Global Health Institute, we were able to do extrapolations from existing data, and the results are stunning. If one looks at the gap between the quality that we have on the planet, especially in low and middle income countries, and the quality of care we could have, based on best available practices, the annual toll in deaths alone in low and middle income countries and globally looks like it's somewhere between 5.7 and 8.4 million deaths. Those are deaths attributable to the gap between the quality that is delivered and the quality that could be delivered technically. To give you some sense of the size of that number, even at the lower limit, that is more than all the deaths in the world from HIV, tuberculosis, and malaria combined. In other words, poor quality is a major source of loss of life and well-being on the planet. It also is a source of loss of Treasury. We estimated only the cost due to loss of productivity due to the deaths and disabilities that devolve from poor quality in low and middle income countries, and that amounts to $1.4 trillion to $1.6 trillion every year, and that does not count the induced costs in health care that are necessary in order to remedy the damage done by poor quality to patients who therefore need to receive even more care. Now, remember that all of this is extrapolated from the limited evidence we have, and one major finding on the burden is that we actually have a scarcity of generalizable evidence on the burden and on the policies and finance strategies that could result in closing of this quality chasm. And we do not yet have a global commitment that we're calling for the use of outcome metrics so that we actually can track the burden of healthcare quality globally. So that leads, next slide, to the recommendation we have about the prioritization of the improvement of quality on a global landscape. We firmly believe that the ongoing and continual improvement of the quality of care and all of the dimensions of quality should be the daily work of healthcare leaders, including but not limited to ministries of health. This involves multilateral and bilateral organizations as well as national and subnational organizations. We're urging that every Ministry of Health should develop a national healthcare quality strategy with supporting policies, and there are examples of such strategies that are available on the globe as models. Every Ministry of Health should adopt goals for closing the quality chasm, improving quality of care in the national context, and we think that this should be taken under cognizance also by the United Nations systems organizations. A lot of this will require high levels of public demand. The amount of change we're going to be calling for is extraordinarily large, and this will not be achieved just from will within the healthcare delivery systems, but will require will from the public at large, and therefore we're recommending a large-scale endeavor at all levels of aggregation to activate the public in the demand for healthcare quality. I want to make it clear that we speak here in this recommendation about dimensions of quality. In the original Institute of Medicine Crossing the Quality Chasm report, there were 6 dimensions outlined: safety, effectiveness, patient-centeredness, timeliness, efficiency, and equity. Our committee took those dimensions under advisement. We did evidence-based reviews of the evidence we have on those dimensions. We modified slightly the dimensionality, but we still call for 6 dimensions of quality to be the targets of work under this recommendation. Next slide, please. Now, all of this is occurring in the global context of universal health coverage, Sustainable Development Goal number 3, and we fully, of course, endorse the idea of universality and coverage as an important global aim. Our point, though, is that that will be insufficient unless quality is addressed, and the happy news is that universal health coverage itself can consciously be used as a lever toward the improvement of the quality of care. And we urge ministries of health and healthcare leaders to look at the tools and levers they're given by the pursuit of healthcare universal coverage to improve quality, using finance and coverage mechanisms, selective purchasing, paying for value of care, linking UHC to monitoring and evaluation, including of quality, and to a research agenda that will understand the effect of the policy levers available through universal health coverage as a way to increase motivation, competence, and resources for the improvement of quality globally. Next slide, please. This will require a measurement agenda. We can't improve quality without understanding it and measuring it. This should be undertaken by both ministries of health, by multilateral organizations, and we recognize that there are tools available, such as, for example, the International Consortium for Health Outcome Metrics and others, that can give us mechanisms globally, if we have the will, to track and report on quality of care globally. Patient-reported outcome measures and patient-reported experience measures, so-called PREMs and PROMs, which have now been thoroughly endorsed by OECD, can be part of the mainstay for healthcare outcome quality metrics in pursuit of better care. And this needs to be undertaken as a matter of policy and practice in governments and organizations. Next slide. Now, to do this is going to require more than stressing the current system. The current system is incapable of closing the quality chasm. It doesn't have the tools and mechanisms to do that. It's not designed well enough to do that, nor does it have the resources necessary. And so our committee very consciously wanted to address the agenda of closing the global quality chasm from the viewpoint of the future healthcare system. I'm going to speak a bit about the designs we have in mind, and then Sonia will talk about one very important element, and that is the coming digital era of healthcare. Next slide, please. Now, the Institute of Medicine report, Crossing the Quality Chasm, specified 10 simple rules, they were called, for the redesign of healthcare systems. The basic idea here is that the deficiencies we're looking at are properties of the systems themselves, of the system designs, and that only changing healthcare systems is going to allow us to transform results. Transforming design is a predicate to transforming results. And so our committee worked very hard with a really important subcommittee to come up with the design principles that we think ought to be the mainstays for the redesign of healthcare systems in all settings, but especially in low and middle-income countries. These design principles shown on the next slide are rather complex and they require study, but let me briefly review them with you. The core idea is that systems thinking, the transformation of healthcare as a system, not as parts, is crucial to redesign, and that the constitution of healthcare redesign needs to be prioritizing the needs of patients, staff, and the community at large. We come down firmly in favor of evidence-based decision-making, which is not currently reflected in the phenomenology of delivery globally. That's one of the major gaps in quality. That each country is going to have to adapt its system design and priorities to local societal values and priorities. We're urging integration of care across what we call the patient journey, especially in the era of non-communicable diseases. We have to think about the well-being of patients over space and time and not just in individual transactions with patients and families. We're going to speak to the optimal use of technology. Sonia will get at that shortly. And these all have to be aligned by leadership, policy, and incentive systems, and the burden on ministries of health and healthcare leaders that we're urging is severe. We need transparency. We need upstream thinking about solving healthcare problems at the source. We need to make sure that we have policies that allow the preparation of healthcare professionals to co-design the transformation of care delivery systems. And it has to be a learning system, as I'll speak to a little bit later in this call. This involves many, many disciplines. This is not just about what doctors and nurses do, for example. And the essential role of thoroughly invested leaders is core to our recommendations. We are calling upon leaders to take quality improvement as fundamental to their major tasks. Now, we're also imagining a new healthcare system, one that's heavily informed by digital transformation, and Sonia will now walk us a bit through our thinking about that transformative environment. Next slide, and back to you, Sonia.
Well, thank you very much, Don. You heard Don say very clearly that the health systems of today and the health systems of the future will be very different from what health systems have been in the past. And when we talk about the digital transformation, when we talk about the transformative potential of technology, even if we don't jump ahead to the blockchains and the artificial intelligence and the Internet of Medical Things and the robotics and the drones and the immunotherapies that are in the pipeline, even if we don't talk about them, even today, the way cell phone connectivity is burgeoning, the manner in which Internet access is becoming universally available opens up a number of different opportunities. There are, in many low and middle income countries, there is this transition straight to 4G and 5G, which opens a number of different opportunities which the market is capitalizing for profitability, for efficiency, for cost containment. We know that the world is on track to meet the Internet connectivity-related sustainable development goals. We know that at least 3/4 of the population of this world already has cell phone in their hands, and the projections for 2050 are stunning. In fact, one of the most important indicators of development today is cell phone signal, as opposed to the other indicators that we've been using in the past, availability of water, sanitation, for instance. This is not to undermine the importance of the other public health measures, but just to bring to bear the opportunities that are opening up for different sectors, including the health sector, with the rapidly burgeoning technology. So recommendation 3.1 has evolved in the context of the opportunities that digital technologies and innovations of today and tomorrow present to forge quantum strides in quality improvements. And basically, recommendation 3.1 calls for the establishment of a global community which can shepherd the mainstreaming of technology and digital advancements for quality improvements in ways that are sustainable for healthcare systems. Essentially, we are talking about the role of the international shepherds, the international stewards, to build institutional capacity in countries so that they can reap the benefits of technology. We have recommended that the United Nations system should convene an international task force with multisectoral representation to provide guidance in relation to the advances that we just talked about, the needed normative guidance, the need to develop data standards, norms, ethical frameworks, and the frameworks for regulatory arrangements in human resource capacity. Our committee has recommended that such a task force should also develop engineering and design standards that emphasize interoperability, human factors, and human-centered design. And additionally, we recommend that such a structure should serve also as an international resource to guide countries and help build their regulatory and oversight capacity.
It looks like we lost Sonia's audio. She will be calling back in.
I can continue if you wish.
Thank you.
Okay. So next slide, please, until Sonia rejoins us. So in order to make sure that the digital future is correctly embraced and leveraged, we're going to need national governments to prepare for that and to adopt frameworks at the national level to support, encourage, and regulate the adoption of the technological changes we're talking about. Digital medicine is going to require a different regulatory frame in order to make it safe for patients, families, and communities. So our recommendation does not just apply to a multinational task force effort, such as Sonia talked about, but involves national policy as well.
I'm back in the meeting.
Go ahead, Sonia. Please go ahead. I'm on slide recommendation 3.2.
I beg your pardon, sir. The line disconnected. So when I fell off the grid, we were talking about the previous recommendation and the responsibility of the international system. Recommendation 3.1 is a mirroring recommendation, and it focuses on the corresponding normative role of countries as opposed to the global development community. And therefore, we have recommended that countries should prepare for and embrace the technological changes that are charging at us, and that they should have the capacity both to adopt, but then more importantly, to adapt the global standards to their local realities, to their local resource realities, to the design of their healthcare system, and develop corresponding ethical frameworks and realign their governance, payment, regulatory systems, and also design their workforce alongside. We've emphasized the importance of intersectoral collaboration within this context because a lot of times it is not within the purview of the competency of the ministries of health to develop the data standards and the oversight arrangements that are needed to tap the benefits of the technology revolution. And therefore, we have stressed and emphasized the importance of engagement with the ministries of communication technologies. We have emphasized the need to develop joint national health strategies. And in terms of institutional arrangements, we've called upon governments and organizations to support intersectoral and multisectoral task forces to guide digital health strategies. And I'm sure you recognize the subtle difference between multisectoral and intersectoral, because with multisectoral, we're talking about engagement between different factions of the government. And with intersectoral, there's an implication for the private sector to be invited to the table as well. We have also recommended that the government and private sector leaders should revise competency requirements and educational curricula to reflect those competencies, because the human capital of the future, and even today, the human capital requirements are very different from the human capital requirements in a health systems frame of the past. And therefore, it is not enough to say that we must re-engineer the systems. It is not enough to say that we must embrace technology and to develop all the frameworks and the regulatory parameters and oversight arrangements. All these cannot be achieved unless there's human resource capacity to design them, to institutionalize them, to get them implemented, to get them monitored and up and running for the desired outcome. Next. So there are sections of this report that deal with some very new and possibly controversial ideas. So moving now on to the next slide, which deals with informal providers. As you will recall, right at the very outset, I had mentioned that there are three special areas that our report deals with: the issue of informal providers, the matter pertaining to corruption, and the matter related to quality issues in situations of extreme adversity. So I'm just proceeding ahead with the first area, which is informal providers. Our committee felt that it would be an oversight to neglect to mention the providers without formal training who operate outside the purview of regulatory controls. But we have to be mindful that the size of the informal sector varies by region, and there's a caveat relating to the fact that very little is known about the quality of care they provide. However, in some regions, they play a predominant role in healthcare delivery. For example, there's evidence that over half the providers in India, 3/4 in Uganda, and almost 90% in Bangladesh are not formally trained. So the committee strongly felt that this sector should be acknowledged, leveraged, and their scopes of practice should be clearly defined. And if we jump on to the next slide, with reference to recommendation 5.1, you see that notion crystallizing into a specific recommendation. We are asking country governments to integrate informal healthcare providers into their national health strategies and quality monitoring and improvement efforts. And this, in effect, creates a number of imperatives for changes in health information systems, appropriate reconfiguration of training, healthcare provider education at various levels, changes in ongoing education, the creation of appropriate regulatory frameworks, arrangements to accredit them and credential them, and each one of them have specific policy, legislative, institutional, and resource requirements. So this is work that needs to be done in the country where in the region that I come from, more than 80% of the healthcare delivery is by informal providers. A lot of them are private sector providers who are trained under various disciplines of care, but they have remained the blind spot of ministries of health, and it's about time. If we've got to talk about quality as an endpoint, as a starting point, we have to recognize them, and the other steps can then follow. Next one, please. So the second situation, this special situation, is the situation of adverse settings. Our report is concerned with the quality of care in these settings immensely. The OECD estimates that about 1.8 billion people live in fragile states. This includes places that range from, for example, Venezuela, where the economic crisis and an unstabilized whole society. This also includes places like Afghanistan, which has seen almost constant war since the 1980s. This, for example, also includes the conflict zones of Yemen and Syria. And this also includes the healthcare challenges that the largest migration wave in history since the Second World War has ushered in terms of issues of maternal, neonatal, and child health and communicable diseases, and the neglected realm of non-communicable diseases for conflict settings. Simply, in adverse settings, there is there isn't a reliable system for healthcare. We reported in the report that over 20% of quality-related neonatal deaths and almost 12% of quality-related maternal deaths occur in such settings. And this is really astounding. But there isn't a reliable system for documenting all these things in a sustainable manner and then addressing them on an ongoing basis. Our report clearly acknowledges that addressing quality in fragile settings is complicated. It is multidimensional. There cannot be a single prescription. But we also recognize at the same time that not much headway has been made in this direction. This has not been a priority for most governments or international organizations. And wherever there have been humanitarian missions, the focus has really been on a very narrow set of issues. And therefore, if we go to the corresponding recommendation, and if we flick the slides to the next page, and if we go to recommendation 5.2, you will notice that this deals with this issue explicitly. We have clearly recommended that settings of extreme adversity should be a high priority. We have called upon national governments, we've called upon multilateral institutions, the humanitarian system, INGOs, which increasingly work in these areas. We've called upon bilateral donors who contribute and the other philanthropic partners which bring valuable monies to the table. And we have urged them to identify priorities for assessing quality in these settings. We have urged them to address conditions that are particularly burdensome in these settings, such as conflict-related trauma and mental illnesses, and the issue of non-communicable diseases, which remains, in most instances, totally unaddressed. Can I have the next slide, please? This report also talks about corruption, which, as you know, can take many forms in healthcare. Corruption in all its forms, whether it is informal payments or pilferage of funds or absenteeism or procurement rent-seeking or the various shades and hues of nepotism or regulatory collusion or state capture, is an enormous contributor to poor quality worldwide. It is also a serious financial problem. Estimates in 2015 clearly indicated that of the $7.35 trillion spent annually on healthcare, about $455 billion are lost to fraud and corruption. I repeat, of the $7.35 trillion spent annually on healthcare, $455 billion are estimated to have been lost to fraud and corruption. This is a huge cost. In our report, we outlined the three determinants of corruption, especially in mixed health systems, and we illustrate how they interact. We outline how corruption can exist sporadically. We give examples of that. And we illustrate with examples how corruption can get institutionalized and transition from becoming the cost of business to becoming the actual business itself. And then finally, we give examples of efforts to fight corruption. In the next slide, with reference to 6.1, we make a specific recommendation to address this problem. We speak directly to ministries of health, and we urge them to recognize this as a problem. Corruption within health systems, its sporadic occurrence, its institutionalization, has remained the blind spot of health systems, full stop. And we urge the ministries of health to recognize this. We urge them to address this as part of national health strategies, to build safeguards, to take specific action, to institutionalize measures, to reward integrity in health systems. And we call on them to draw on expertise outside of the healthcare system for efforts that can be aimed at prevention, detection, and enforcement. And I think that there are many highlights of this report, but the focus on corruption very squarely is clearly something for which the report will, we hope will be remembered. And I really want to thank all the colleagues around the table for their steadfast support to highlighting this as a major problem. So let me invite you, Don, for your reflections and for taking it forward from here.
Thanks. Thanks so much, Sonia. All right, so we're calling for a lot of changes. We're calling for a refocus on quality and integration with the universal health coverage agenda, and we're saying that that can only be achieved by fundamental redesign of healthcare systems and addressing the three knotty problems that Sonia just mentioned. Redesign won't happen through exhortation or demand or even incentive. It's going to require a different culture in the healthcare systems that want to close the quality chasm. We refer here to a culture of learning. Next slide, please. The idea of a learning organization has a long pedigree now, both inside and outside healthcare. And in the recent work of the National Academies of Sciences, Engineering, and Medicine, there's actually a stream of reports that define what a learning healthcare system looks like. The opposite of a learning healthcare system is one that uses blame and fear and demand, simply requirement and objectives, as opposed to continuous learning as a way to do its work. We understand a lot about what healthcare systems that can learn look like. We know it begins with leaders, and we're urging in Recommendation 8.1 that healthcare leaders in all settings, and I'll say including ministries of health, really need to master and adopt the vision and the culture of learning healthcare systems in which continual learning, as opposed to blame and shame, become the watchword for activities in the healthcare system all the way through, from the ministerial level to the front lines. This involves everybody in the pursuit of the learning culture. Next slide, please. The nature of a learning organization is rather too complicated for the limited time we have left in this call, but it involves setting up opportunities for continuous trial of change at the local level, supported by clinical and non-clinical leaders throughout the healthcare system. It involves an environment of safety in which people are able to try to change their systems over time, to try and fail and then succeed. And any system founded on fear and reactivity and demand will not foster the kind of transparency and willingness to try that we're talking about in the learning organization. So for purposes of this call, I'll simply call everyone's attention to the concept of a learning organization and our committee's firm stand behind the adoption of the learning culture at all levels, from government to frontline, as absolutely essential. This is best done through collaborative learning, in which multiple organizations, even multiple nations that are trying to solve the same problems around the quality chasm, get together and do that together. And so we're urging mechanisms, national, multinational, regional mechanisms for collaborative learning about improvement and innovation in healthcare as a much better road to achieve the closing of the quality chasm that we're talking about. And this should, the coming digital health technology era should help that, as we can move communication and knowledge much more speedily through the healthcare system. So adopting the culture of a learning system matters a lot. We explored very specifically whether that can apply in low-income settings, and we know it can. We've seen examples of that in testimony to the committee and in the research of the staff, and our report contains a number of examples in which we've cited learning healthcare systems in even very low resource settings. Next slide, please. We discovered that much more is not known than is known about what we wish to know about the state of quality multinationally in low and middle income settings, and about which interventions are most effective at helping quality improve. The sister report from OECD, World Bank, and the WHO that issued last month is full of information about that, and we are urging a major international agenda on research related to the pursuit of the quality agenda. The next slide, next two slides show you some of the research questions that we've called out, and Recommendation 8.2 in our report actually lists a whole series of questions that we now believe are important around developing models and data for the support of closing the quality chasm. Rather than spend time on reciting these recommendations, I think I'll just call them to your attention so we can proceed to questions. The final slide reminds you about the availability of the report online. It's available to you as of this morning. We hope everyone will take it under advisement, read it, and put it into action. With that said, let me turn it back to my colleagues on the staff, and Sonia and I are prepared to answer any questions that we have time to address. And thank you very, very much for your attention in this launch.
Thank you very much to Don and Sonia for that presentation. We will now move into Q&A, so please go ahead and submit your questions in the lower right-hand corner of your screen. First question to start us off: how does the committee approach non-communicable diseases versus communicable diseases for improved quality?
I'll start and then ask Sonia to comment, since she chairs the WHO Committee on Non-Communicable Diseases. I think the core idea that is relevant to that in our report is the idea of the patient journey. Much of healthcare is organized, too much of healthcare is organized around individual encounters and deeds, instead of understanding the needs of patients, families, and communities over time and space. And so if you read our report, you're going to find a lot of commentary around redesign around the patient journey. I'll also add that a lot of the burden that we found from poor quality does apply to mismanagement of non-communicable diseases. Some of the numbers are stunning when you look at the available evidence on proper management of people with NCDs and what actually is happening in the field. Some of the reliability numbers approach as low as 10% of the care being given actually adheres to the standards that we now have scientifically from proper management of NCDs. Sonia, since you chair that crucial committee, maybe you want to make a comment or two.
Yes, thanks, Don. So, as you probably know, NCDs also have been the blind spot of public health. NCDs are the major global killers, and I can go on and on with the rationale for prioritizing them at the primary health care level and at the secondary and tertiary care level. But the bottom line is that they have remained outside of mainstream public health and clinical care planning and prevention planning. And therefore, because the programs have not been up and running, especially at the primary health care level, the quality issues that arise in settings of chronic care have not received attention as well. But wherever they have been for communicable diseases, wherever chronic care platforms have been established for communicable diseases, such as for HIV, AIDS, and tuberculosis, we know that the quality considerations are unique and specific, and they need to be addressed. So as hopefully NCDs get mainstreamed into primary health care systems, we will get better understanding of what those are, and hopefully we could realign our systems design to better respond to those. Also, just reflecting quickly on some of the areas in the report, we have estimated the overall number of deaths from poor quality care annually in the low and middle income countries from the work that colleagues at Harvard have done, as Don just mentioned. And for communicable diseases, the estimates are 0.86 million. For non-communicable diseases, it is a staggering 4.11 million. So it is really almost 4 times the amount of the burden of communicable diseases. Also in the report, we cite one study from Kenya, China, and India, which has found that providers adhere to evidence-based treatment for both for conditions such as asthma and chest pain, which fall in the non-communicable disease bracket, vis-a-vis diarrhea and tuberculosis, which fall in the communicable disease bucket. And the findings were that they adhere to evidence-based treatment only 25 to 50% of the time.
Thank you. Next question is, how does the committee envision addressing informal payments and exploitation by health systems?
Sonia, perhaps you would comment on that.
So informal payments can be sporadic. So let me just take one step back. When you talk about collusion and corruption in health systems, you look at a spectrum, and on one end of the spectrum are the practices which could be classed, for lack of a better word, as individual coping strategies. Now, those could be sporadic, but those could be well institutionalized. And at the other end of the spectrum, as you go further down, and as corruption gets institutionalized, you start seeing patterns of regulatory rent-seeking. It becomes more systemic, and ultimately we move towards the state capture end of the spectrum. So informal payments can be sporadic, but when they get institutionalized, that's when they become extremely worrying. The response to them is, of course, to reward integrity, to realign incentives, to move towards better remuneration, to compel accountability for wrongdoings. There's a whole range of remedial measures that can come into play depending on the context, depending on what accompanies these behaviors, and depending on a number of different contextual factors.
Thank you. Next question is related to the data analysis. Can you just talk a little bit more about how that between 5 to 8 million deaths are attributable to receiving poor quality care, and the other finding related to the loss of productivity?
Yes, we have to credit a committee member, Ashish Jha, and the Harvard Global Institute, Global Health Institute, which had a subcontract from the committee to do this research work. It's well documented in the report and appendices. The model used essentially took the available data that we have on the quality of care for an index set of very serious conditions that are associated with mortality globally. I don't remember the exact number, but 8 or 10 conditions. Looked at the results that we have seen in terms of process measures and outcome measures for those conditions in the available data, and then compared that to outcomes that are achieved in highly developed countries with very good systems for management of those particular conditions, best practices. That established a gap between the practices we know and the best practices we know, and from that gap was estimated potential lives lost and costs of lost productivity attributable to those life years adjusted for the age of the victims. It's a very well-developed model, and I want to credit the group that did it. It is only a partial model. It did not include all conditions by any means, so it's a set of index conditions. And remember, we're working with extrapolation from available data. But again, that information is well documented in the report and appendices, and I think you'll be seeing publications emerge from Professor Jha's group about that research over the months ahead. Sonia, do you want to supplement that at all?
No, I think you've well summarized it. Thanks.
I have to tip my hat, by the way, to someone that testified to the committee and whose work affected us a lot, and that's Jishnu Das's work at the World Bank. He's not alone, but he was one of the major influences on the data that we have based on his use of simulated patients in real-world settings in low- and middle-income countries. Very important work.
Thank you. We're going to go a little bit past 10 Eastern just to take a couple more questions. So how can we leverage the informal sector?
Sonia, would you like to comment on that?
So, I mean, it's easy to say that they should be brought within the regulatory framework. So there are various policy approaches that you could use to leverage their outreach and their skills and their capabilities. One of them is through the regulatory approach. The other is through documenting them, and these are, of course, not mutually exclusive. The third is through contracting, because if work starts getting contracted to them, they automatically we will automatically start documenting them. They will automatically come within the regulatory framework. Then there are some financing strategies which are applicable as well. If you start purchasing from them, so contracting and purchasing, there's a subtle difference between the two. But if you could use purchasing as a tool, you slowly and gradually start documenting where they are, learning what they do, gather information on them. And that is the route to start harnessing their potential and their outreach, as well as stipulate certain preconditions within which quality parameters can be embedded. So there are various, to summarize, there are various policy approaches which can be used as entry points.
We're well aware that this may be among the most controversial of our recommendations. But as Sonia said, when in countries 70, 80% of the care is being given through the informal sector, we just don't believe that it's responsible not to try to find ways to embrace and encourage and work with the informal sector toward the improvement of quality. That would be turning backs on the experiences that patients seek. And the public is voting with its feet. They go to the informal sector, sometimes because other care is not available, sometimes because it's a more comfortable place for them to be. So we are, and we think controversially, recommending that ministries of health take this under advisement and find ways to connect to the informal sector in much more robust form than they currently do.
And just to add to that, can I just quickly add to that? I mean, this is, there are very many nuances within this place, because a lot of times, in many settings, informal providers are doctors, the allopathic registered doctors who have not been documented and catered for within government systems. In other places, there are genuinely informal who have not been trained for anything, but they're providing services. And yet in another setting, these are providers who are qualified to do something else, but actually are providing services that are totally different. So for instance, a lab technician goes and poses as a doctor. So there are different settings, and it's difficult to give a policy prescription that applies to all of them, but there are approaches that are uniquely suited to each setting which can be incrementally adopted. And Don very rightly says that in a certain category, this can be a very highly charged discussion.
Thank you. And our last question, I'm going to kind of combine a couple sort of forward-looking ones. So what role do partner academic institutions in high-income countries play in the quest for high quality in low and middle-income countries? And also, what are your plans for dissemination of this report, especially with governments of low and middle-income countries?
We have begun dissemination through several publications and are working with the World Bank, WHO, OECD, and the Lancet Commission on ways to take the 3 reports and perhaps have 1 or more public sessions in early 2019 in which we'll be discussing those reports. Sonia Nishtar, Megan Reeves-Snair, and I have co-authored a paper that will appear next week in JAMA that summarizes this report. And we're seeking other publication outlets and have assessed both speaking and publication opportunities for committee members. But, you know, taking this report into action is going to require a lot more than the committee continuing any work at all. We're really asking ministries of health all over the world to take this under advisement now. The burden is enormous, and we're calling on public and private sector to recognize this and carry this ball forward. Son, you may want to talk about your other thoughts about how this report can move into action, because the last thing we ever want to see is that this report just stays on a shelf. The burden is much too great.
No, I think you've well summarized the efforts that are underway. Of course, the most important phase in the life of a report of this nature actually commences after it is placed in the public domain. So clearly there are some activities that are planned, they are budgeted, there are some individual committee members have taken upon the responsibility to draw attention to the report wherever they've been asked to keynote or speak or wherever they're traveling. There are major dissemination events planned at international locations. We are also, toying with the idea of an accompanying documentary. There are various ways in which this can cascade into policy briefs, and Twitter storms and so on and so forth. We have linkages with ministries of finance through the World Bank, with ministries of health through WHO, with a range of academic institutions, and there are myriad ways in which dissemination activities can be planned. As we said, some are in the pipeline, and we're going to get together to ensure that this does not stay on the shelf. With regard to the first stem of your question about the role of academic institutions, clearly academic institutions in the North with capacity, with human resource, with experience can play a very salient role in helping developing country governments in terms of scoping needs, in terms of helping them developing frameworks that are locally relevant to their needs. They can play a very important role in helping them cascade these frameworks into implementation and evaluating them in an independent fashion. And we hope that the seeds of this collaboration that we have sown through some of our recommendations will actually bear fruit as we plan dissemination activities in the way forward.
If I could just add, someone texted in a question about the other two reports that we're referring to. Let me repeat what those are. The World Bank, WHO, and OECD have issued a report last month on global quality, and it was available to the committee during our deliberations and addresses some of the evidence behind especially policy-based changes for the improvement of care. It's available online. On September 6th, there will be a launch of a report from the Lancet Global Commission on high-performing healthcare systems, and that commission has done work quite parallel with ours in that report we are all looking forward to.
Thank you to you both, Don and Sonia. That's all the time we have for questions today. Once you exit this webinar, you will be redirected to our report page where you can find the report and other supporting materials, including some videos at www.nationalacademies.org/global health quality. The slides from today's webinar and a recording of this webinar will also get posted to that page. And with that, I'd like to thank all of our speakers and thank you all again for tuning in today.
Thank you.
Thank you.